So I wanted to just change up a little bit. I feel like we have a couple more patients who might come in a minute. Instead of just doing a PowerPoint after PowerPoint, I thought I'll just do a whiteboard, go back to school. I won't pick on anybody. Feel free to chip in with thoughts and ideas. So great. So the two topics that I was supposed to cover are CIDP and MMN. Just so that we are all on the same page, neurologists are, I think other physicians do it too, but neurologists are notorious for coming up with these abbreviations like CIDP, MMN, and then there are variants of CIDP called CISP, DADS. I won't go into so much of those things, but we are well known in the field for doing these things. Part of the reason we do them, part of the reason we come up with all these acronyms is because we want to get to the diagnosis as precisely as we can, and sort of while capturing all the nuances of different diseases and how they might interact. But I think Dr. Goel earlier pointed out like the different aspects of the nervous system, and then Dr. Day also pointed out different aspects of the nervous system. So if you think of your spinal cord, and then you have a nerve that comes out, and then you have a muscle that it joins. So I'll do muscle, I'll do nerve, I'll do spinal cord. When you think of just the nerve, right, that's just the nerve. But the reality is that nerves have different components to it. There is think of nerves as like the electrical wiring inside your home, for example. So the nerve has the nerve part, which is called the axon part. And beside the axon part, or around the axon part, you have the myelin part. In this case, it's like the green drawing, for example. So there is nerve, the axon part, and there is the myelin part that's around it. And the reason it's important to know, when you have any nerve problem, we call it neuropathy, as in nerve disease, that it can be of either one of them. It could be the axon, inside part. It could be the myelin, outside part. And so you guys will catch up with the theme. If it's axon, so primary axonal disease. Now, when it's myelin, this is where neurologists will switch you up. We call it demyelinating disease because the myelin is being taken away. So that's demyelinating disease. And there are few autoimmune diseases that preferentially affect the myelin part, the green part in this picture. And there are quite a few of them, but we'll talk about two diseases in this cohort. There's a lot of interest in them. There are quite a few patients who have these two diseases. There is few therapeutic options, potentially a lot more going forward. And there's the two of them. One is called CIDP, and another one is called MMN. And so this is where it gets tricky if you haven't sort of primed yourself to following along a little bit. Different words mean different things. So C stands for chronic because it's been going on for a while. Now, if you're purely scientifically approaching it, C stands for chronic. In our case, we define chronicity as more than 8 weeks. Okay. I stands for inflammatory, essentially autoimmune disease. Yeah, please come and have a seat close by. Yeah, thanks. D stands for demyelinating. P stands for polyneuropathy, as in multiple nerves are affected. Marie will remind me, polyradiculoneuropathy is like the much more closer word because the nerve roots are also involved, not just the nerve, but for normal language is CIDP, polyneuropathy. And so this condition, we'll talk about CIDP and we'll come to MMN in a few minutes. And so for the CIDP part, chronic, immune-mediated, or inflammatory, demyelinating polyneuropathy. We can go backwards. Polyneuropathy means multiple nerves are involved. Generally, patients will have weakness and numbness and pain because nerves are involved, causes neuropathic pain or nerve pain. Weakness can be of different muscle groups. It could be weakness of your feet, for example, so you have difficulty walking. Foot drop is where you're not able to lift your foot all the way up. You can have weakness of your hip muscles, so difficulty climbing up steps, for example. Difficulty of your hand muscles, you're not able to make a grip. You're not able to take the gallon of milk out of your fridge. Weakness of your shoulder muscles. So those are all weakness. You can have numbness. So you can have numbness in your feet. You're not able to feel the ground well. So if you're not able to feel the ground well, you can't walk in a stable way. You have a lot more imbalance while you're walking. You feel unsteady. When you're taking a shower, for example, you might feel, oh, I'm about to fall down. Because when you take a shower, we all close our eyes for a few seconds, and then your balance is off. And patients can have progressive weakness over a period of few weeks. We talked about the demyelinating part. Now, as a patient, you wouldn't experience anything about the demyelination. That's for the neurologist trying to figure out, is that the problem or not. Chronicity, of course, you would experience because it's been going on for a few weeks. Right? It's one of the more common autoimmune neurological disease, a nerve disease. And how do we diagnose this? So we examine patients, and we say they have both proximal and then distal weakness. So weakness proximal, distal, which proximal is shoulders and hips. Distal is hands and feet. So they have that weakness. Second thing that they have, again, although I've had patients who tested their own reflexes and were checking it themselves, but most of the time, most patients don't need to check their reflexes. But they have something called areflexia, as in reflex is absent. And so that's when we examine you, or your doctor examines you and say, okay, you don't have reflexes everywhere. And then they have decreased sensation, where we examine you with a pen, or we examine you with a tuning fork, and they have reduced sensation in their feet or hands. And those are the different features that will tell you that, okay, there is neuropathy because they have numbness, they have balance impairment, they have loss of reflexes, and they have this weakness pattern. But before all of these will tell you, it's neuropathy. The time will tell you that it's been going on for a while. But this part, the D part, it's difficult to be sure about the D part until you do more testing. And one way we do more testing is by doing a test called EMG nerve conduction study. This is where we stimulate your nerves and we record the signals. And so I don't have an EMG machine to demonstrate it, but I'll just sort of demonstrate it on my hand. So for example, you can stimulate your nerve up here, and then you record from a muscle. One of the pictures from Dr. Goel earlier sort of shows that. So if you stimulate your nerve at the wrist, for example, and then record from your thumb muscle, let's imagine, I'll draw an X and Y scale. And so you stimulate it there. It takes a few milliseconds, and then you get a response from your muscle. And you see a little bump, that's the muscle contracting, and then you pick up the response. Now, I don't have any nerve disease, so if I were to stimulate higher up at my wrist, for example, it will take a little bit longer than when I stimulated at the wrist, right? It's a longer distance. And so it will take a little bit longer. The size of the response should be fairly similar, because again, you're stimulating the whole of the nerve. And that would be how a normal nerve study would look like. Now, if you imagine a patient with CIDP, we'll do the same exercise. And if the nerve is involved in CIDP, we talked about how the D stands for demyelinating. So the A stands for the axon, the inside part. Myelin is the sheath. Sheath is critical for how fast a nerve can conduct. And so just going back to analogies we've been using all day of different kinds, think back to sort of the electrical wiring in your own home. The sheath outside is to prevent the sort of energy from dissipating. And so if you don't have the sheath, the nerve still will conduct, but lot more slower. Or if you have one area where the sheath is damaged, then in that one area, the nerve might not conduct as well or might conduct very poorly. So two things will happen if you have a CIDP kind of picture when you do this nerve testing. A, it might take a long time to go, okay? So when you stimulate at the wrist, it might go a little bit longer before the response comes. Size of the response could be smaller. But when you stimulate higher up and then record from the same muscle, it'll take even longer, and then the size of the response can be smaller. And so we look at these features on the physiology testing and say, oh, that looks like a demyelinating problem, or that looks like a myelin problem, or essentially we would call it a demyelinating problem. So this would be a normal nerve study, okay? And this would be something a CIDP patient or a demyelinating process might look like. And it's where critical, at least for the two neurological diseases I talk about, physiology testing, nerve conduction testing becomes critical as a way of diagnosing it. There is no other simpler way of diagnosing it. You can suspect it based on this clinical picture, but you need the physiology to test it. What other things do we do to sort of support the diagnosis? So you can suspect it clinically. They're progressing, they have numbness, they have weakness, they have balance problems. They don't have any other cause for the neuropathy. They're not a diabetic, for example. You do testing and it looks like, oh, that looks like a demyelinating problem. And then we do a few other things, not necessarily needed, but we sometimes do them. One, we can do a CSF analysis, cerebrospinal fluid analysis. So that's essentially getting like a little spinal tap. You take the fluid and you see if there is any signs of inflammation in the spinal fluid, because that will give you a sense that there is inflammation in the nerves, because the nerves come from your spinal cord area. So that would be one. So patients will have high level of protein in there. That's a marker of inflammation. That's the one way of going about it. Second one, that wasn't always the case in the past, but now we do it and sort of ties into how I'll finish this session, antibody testing. So not everybody, but maybe 10 to 15% of the patients have known antibodies that we can test for. These are the antibodies that work on the nerve where the myelin sheath is. And it impairs the sort of the myelin level. And so that would be another test that we could do. By now, you know, once you know that it is an antibody test, from all the talks from this morning and now, there are lots of different things we could do, because you know that there is an antibody test that's clearly causing the disease. And so those are the two ways we typically diagnose. Sometimes we get a nerve biopsy, we take a sample of the nerve, but that's not a common practice, not anymore, especially because we can get, most of the time, the answer from physiology. You can get these additional supportive data. And one of the challenges about nerve biopsies is that when you take a piece of the nerve, generally that piece of the nerve is lost. It's not reversible. And so we have sort of a higher threshold for taking nerve samples unless we think it's absolutely needed. And so it's an autoimmune disease. It affects the myelin part of the problem, and it can cause these symptoms. It's a progressive disease. So if you don't treat it, things definitely slowly get worse and worse and worse. There are associations with this disease, including some type of blood cancers, for example. So when you see your neurologist, they'll assess for these things, get lab tests to make sure. Patients who have diabetes have a sort of a higher incidence of this condition compared to patients who don't have diabetes. So there are a few associations of that kind. But the thing about CIDP that's very, very interesting is that it's definitely treatable, significantly treatable compared to other forms of neuropathy. So we talked about the fact that some patients have known antibodies that we can test for. There are probably some more antibodies that we don't quite know how to test them yet. So that's where the B cell function comes in. B cells produce your antibodies in your system. Dr. Kang talked about that in myasthenia. There's also a T cell immunity part of the disease that causes the disease. And so the three common treatments that are used as a primary options. One is prednisone or corticosteroids. We talked about prednisone earlier with myasthenia, for example, and we'll talk about it when we talk about inflammatory muscle disease. Second one, we talked about this earlier as well. Dr. Kong mentioned it, IVIG, a commonly used drug. These two are essentially first-line therapies for CIDP. There's no wrong answer if you want to pick one or the other. Different levels of side effect profile that ends up letting you choose. IG stands for immunoglobulin. IV stands for intravenous. So given into the vein, immunoglobulin. There is also a sub-Q IG given subcutaneously under the skin through a pump, and then IG is the same immunoglobulin. And the third option, sometimes we use it, we don't always use it. Again, this topic came up earlier in my presentation this afternoon too, is called plasma exchange or plasmapheresis. This is where we take your blood, filter it back, and give it back to you. The idea is that you take away these antibodies that are potentially causing the disease. All three of them can be used. These two are the commonly used options to begin with. Prednisone, unfortunately, comes with its own side effect profile. IVIG requires that you need to get it through an IV, and so that sort of poses its own limitations, but fairly effective options. And then very rarely, if patients are doing really poorly and it's been a challenge, we can use the plasma exchange option. Now, these are what we use at the beginning of the disease. So once, let's say I have CIDP, I get diagnosed with it, these would be the first things that Dr. Goyal will tell me. These are your options, Sri. Which one do you want to pick? What's best for you? So on and so forth. Once you figured out what's the best one for you to begin with, and as you're seeing what kind of response you get, we choose other oral drugs. These are long-term immunosuppressive drugs. Again, Dr. Khan talked about it for the myasthenia part. These are the same drugs. There's no special drug for CIDP. They're the same drugs because all of these drugs, I had mentioned in the morning talk, are non-specific immunosuppressive drugs, right? So these are the drugs like azathioprine. Another one that Dr. Kang talked about is Cellcept or mycophenolate. These are oral drugs. We start them early in the disease process once we figured out what's the best initial treatment, with the idea that these drugs, since they're taken orally, might simplify either the requirement for the prednisone with its side effect profile, or requirement for these infusion therapies, or even requirement for something like plasma exchange. The novel things about CIDP, and I had one slide in the morning about it, we all learned today that if you have an antibody-mediated disease, there are all these therapies, the FcRn therapies, that can reduce the antibody levels, and then that can give you a benefit. So Vyvgart, Dr. Kang mentioned, which is FDA approved for myasthenia, has been tested. The subcutaneous form of it has been tested in CIDP. At least the published clinical data is very promising. It's not approved, but hopefully that will lead to other FcRn therapies for this disease. So beyond that, we sometimes use off-label things like rituximab. Sometimes we use in myasthenia as well. We use even stronger sort of almost chemotherapy drugs like Cytoxan, for example, or cyclophosphamide in patients who are doing really poorly and struggling and not able to sort of get back to their original level. The thing about CIDP, it's important to remember, from this session at least, it's definitely treatable. If you were to check Dr. Google neuropathies, it doesn't always say everything is treatable, but this is definitely treatable. And so as clinicians, we would never want to miss a case, or we would never want to undertreat one of these syndromes, because this is one of those things where there is a significant potential for reversal, irrespective of the degree of the damage that we might see at the beginning of things. Yeah. So we'll move on to the next part, next slide. This one is a little bit more tricky, a lot more rarer, and goes back to my theme of sometimes neurologists come up with, oh, yeah, sorry, go ahead, ma'am.
So myasthenia gravis and CIDP?
What is the incidence? I think myasthenia gravis is about maybe 60 to 70,000 in US. I don't know the exact number for CIDP. Oh, somebody who has both of them. I think I've only had one patient in many, many years of practice. I haven't had many. That patient definitely had myasthenia, had thymectomy, and she's on treatment. And she also had CIDP because it was diagnosed by us and by another prominent neurologist in Southern California by physiology. But I have not, I've only seen that one person. Good question though. These two antibodies, even though they can be antibody-mediated diseases, we don't think of those antibodies as sort of cross-reacting because they have completely different targets. The antibody for myasthenia is a completely different target compared to the nerve target. They both are autoimmune, absolutely. There might be situations where one might have more than one antibody for reasons unclear, or if there is a cancer or some other process that's kind of helping them create all of these antibodies, yes. Myasthenia as a disease, I don't think any of us covered that, is frequently associated with other autoimmune diseases. We don't think CIDP would be one of them. Myasthenia is usually associated with thyroid autoimmune disease, so on and so forth, but it can be. Good question, though. Thank you. The second one I'll cover next 5 minutes or so is called MMN. Even rarer disease than CIDP, but again an autoimmune disease. Going back to the theme of neurologists coming up with abbreviations, everybody knows by now what N means. I'll poll the audience. N. You guys are great. Thank you. Nobody has fallen asleep. It's great. M stands for motor. Motor refers to strength. Sensory refers to sensation. And then here, M, it stands for multifocal. Multiple areas, focal areas of the nerve. And so it's almost like imagine, take the nervous system, and you have all of these different areas where you're involving one nerve here in this hand, one nerve in the left foot. So that would be focal nerve, but multiple areas, And then motor, it's only involving the strength fibers, and it's neuropathy because it's primarily a nerve problem. So classically, patients complain of weakness because it's purely motor. There's no sensation involved with this process. And it could be multiple areas. So they might say, oh, I'm not able to lift my fingers up because the nerves that lift your finger up is affected. They might say, oh, this happened 3 months ago, and now I'm not able to lift my left foot up because the nerve that supplies the left foot is affected at a later point. So that would be two different nerves, right? They're not continuous, obviously. And then there are focal areas, and then it's neuropathy. They don't have any sensation problems. They usually don't have any pain. And from my little tutorial on electrophysiology, again, we do the same thing. We diagnose it based on physiology. So if there is a focal nerve problem that's affecting the myelin, again, we don't use the word demyelinating, but there is a focal area of the nerve. If that's the nerve and then the myelin is outside, there's an area where there is impairment of the myelin function. And so when you do the physiology testing, you can see the reflection that that particular area, the myelin, is not working well. Because when you stimulate above the myelin area not working well, you don't get the same signaling. There are also antibodies available for this test. Not everybody has those antibodies, but the antibodies are called GM1 antibodies. And one of the biggest reasons this disease should always be thought of is because there could be some potential similarities with things like ALS in how patients manifest themselves. There could be sort of confusion regarding is this ALS, is this MMN? So we always take this very seriously, obviously, naturally, trying to make sure that we have that distinction right. The second important thing to always think about in the right clinical picture is that this condition is very responsive to IVIG treatment. Patients really notice improvement with this treatment. It's the first-line therapy for this condition. Most patients have improvement. If they don't have improvement for this condition, we use other drugs like rituximab or cyclophosphamide to sort of much more stronger therapies, but potentially are an option. Even rarer than CIDP, but it's critical because it's treatable. There is no, you can make a big difference if you capture it early in the disease process. Diagnosis can be challenging because I had just given you a quick two-liner about how the physiology, but the reality is that if you ever done physiology in your training or in school, physiology is never that simple. There's a lot of variability between who's doing the testing, how detailed they're doing the testing. So ideally, it's good to get these tests done at a place where they have a lot of experience in doing these tests. The antibodies, while they're useful, they're not present in everybody. And so there is no single perfect test. But we always think of this because it's very much responsive to IVIG. Again, because of the antibody nature of the disease, there are lots of newer pharmacotherapeutics and newer trials being designed, again, to help, because as we saw today, anytime there is a clear antibody-mediated process, the field has gone towards how does that antibody cause the disease, and how do we change that significantly? And that's in the last 4 or 5 years or so. And so it's an exciting time for this field because there haven't been any therapies for a very long period of time, apart since IVIG, for example. No FDA-approved therapies, but potentially I'm optimistic there'll be a lot more newer therapies available. I will stop there. I'll get my colleague Marie take over, and then we'll have some time for Q&A at the end. Thank you so much.